Hey, it's Dr. Jonathan Rubenstein. I want to talk about how to bill for hospital visits starting January 1st, 2023. On January 1st, 2023, the updated evaluation management codes for hospital visits will be implemented. There are two major changes that we have to be aware about when choosing codes and to be aware about on how the codes are being updated. Number one, the new codes will align with the 2021 E&M guidelines for office and other outpatient visits, where the history section is medically necessary, is what needs to be documented. The physical examination is medically necessary for what needs to be documented, and therefore billing is based upon medical decision-making or time. That same idea and concept will be brought over to hospital billing. And the second thing is the consolidation of the inpatient codes and the observation status codes into one code set to help reduce confusion and improve billing. The objectives of this talk are to understand how E&M services and procedure codes are used in the hospital setting starting January 1st, 2023, how they've been updated from the 1995-1997 guidelines that we've been used to for all these years. Yet still understand the importance of knowing the patient status, their observation, extended recovery, their inpatient within the postoperative global or emergency room when billing in the hospital. And therefore, starting January 1st, 2023 with the update, how to accurately document and bill hospital visits and also associated procedures. So why is this confusing? Well, before, the hospital observation unit was considered an outpatient status. And therefore, we would use outpatient codes or unique observation codes when billing patients who are in the observation unit status of a hospital. Sometimes it's difficult to know and choose the correct code if a hospitalized patient is still in observation or has been admitted to the hospital. What's changing now is that outpatient status will be our office and our ASC, or if a patient is in the hospital, they'll be in the observation unit or inpatient. We'll use similar codes and actually the same codes when reporting those services, even though they're in different statuses. At least we'll only need to use one set of codes. Remember, hospital settings and hospital services include initial visits and subsequent visits. We have to remember that's different than office or outpatient visits, where you have initial and established. There's no such thing as established and initial as much in the hospital setting as there is in the outpatient. The hospital will be the first visit and subsequent visits during that hospitalization. What that means is even if the patient is an established patient to the practice, every time they are admitted to the hospital, we'll bill an initial hospital visit and subsequent hospital visit. Once again, discharge codes will only be billed by the admitting service. So what's important information still for billing, we need to know the patient status. If they're in the emergency room, whether they're in observation or whether inpatient, their insurance, Medicare versus private, because some private insurers will allow inpatient and observation unit consultations. We have to know whether it's the initial visit, subsequent visit, or we're discharging the patient from our service if they are on the urology service. We need to know if the service is being shared with an APP and a doctor. So they need to communicate who will submit and how this is being submitted, whether procedure performed or not. Again, we ask for an ICD-10 code, an E&M and or procedure code with modifiers if applicable, the hospital name, and the patient is an inpatient or observation unit in the hospital. If a doctor and APP are working together, they must communicate who's submitting each day's billing and if a procedure is being formed each day, because it may affect the modifiers being placed on the E&M service. We remember the global concept that procedures all have a global visit that's associated with them, meaning the associated evaluation management service and post-op recovery has been paid already in the payment for the service itself. All the work that's typically done with that procedure has been paid. You only get paid separately if there's something separate and identifiable, which may include an initial visit to a hospital. If a patient is seen in the morning in the emergency room and it undergoes a 0-day global cystostent in the afternoon, the morning emergency room visit is billable. If the patient came as an outpatient, the E&M services associated with the cystostent have been already included and have been paid for in the 0-day global procedure. The global will include postoperative care the day of the procedure, the hospital visits within the global period. Therefore, it's important to know whether it's a 0 or 90-day global procedure or even a 10-day global procedure that's being performed, and also any office visits within the global period. Medicare, all postoperative care, including complications handled outside of procedure room or operating room, are included in the payment from Medicare. 0-day global procedures include cystoscopies, cystoclot evacuations, bladder tumor, cystostent, ureteroscopy, placing a Foley catheter, urodynamics, bladder irrigation, and the BPH procedures such as UroLift, or 90-day global procedures are major surgeries, radical prostatectomy, cystectomy, partial nephrectomy, cryo, ESWAL, sling, TURPs, PVP, Rezum, PCNLs, orchiectomy are examples of 90-day global procedures. What's new starting in 2023 is that the same codes will be used whether the patient is an inpatient or in the observation unit. If urology is the admitting service to either the inpatient unit or the observation unit, the initial visits will be 99221 through 99223. The patient is admitted and discharged same day, 99234 through 99236. Subsequent visits, 99231 through 99233. That's a separate day from the initial visit. The patient is discharged on a separate day, 99238 to 99239. The patient's in the post-op global and they're being seen. We like to report a 99024 just for documentation purposes. If the urology is the consultant to a patient being admitted on another service, we'll either bill the same initial visit, 99221 through 99223, if the insurance, such as Medicare, does not recognize consultation codes. We'll bill a consultation 99251 through 99255 if the patient has an insurance that recognizes consultation codes. Every subsequent day that the patient is seen, a subsequent visit code 99231 through 99233 will be billed. It's important to understand modifiers. As I mentioned before, modifier 25 is the most common modifier that will be used. Significant, separately identifiable E&M service on the same day as a procedure. The example I mentioned before was the patient who was seen in the emergency room in the morning and brought for a cystostent in the afternoon. The E&M service, by seeing the patients in the ER in the morning, a modifier 25 should be appended on it so that an insurance company knows that it is reasonable to bill an E&M service that has nothing to do with the cystostent procedure that will be performed later in the day. Modifier 57 is the same thing but for 90-day global procedures. Modifier 24, if there's an unrelated E&M service by the same provider, physician group during a postoperative period. A common example is a patient has a radical prostatectomy and then comes in with a kidney stone. The kidney stone has nothing to do with the radical prostatectomy. So to build the E&M work of the kidney stone work, add modifier 24 to the E&M service. So what's changed between the old guidelines and the new guidelines? The history must be medically appropriate. No longer do we have to have these 4 click buttons or have 4 descriptors. We should write what's medically important on the patient. The examination is also medically appropriate. So ultimately, the level that's being chosen is based upon time or medical decision-making. Medical decision-making is 2 out of the 3 between problems, data, and risk, which is going to be the same as our outpatient E&M services. To understand problem, data, and risk, please see the other lecture about outpatient E&M services for those details. There are add-on codes that will be present depending on the amount of time that's being spent on the floor and coordinating the patient's care that can be added on for significantly prolonged visits. Starting on January 1st, 2023, we're going to go from the old description, which again has the history, examination, medical decision-making. The new description will be, for example, initial hospital, inpatient, or observation care per day. with a medically appropriate history, medically appropriate examination. And for level 1 will be a straightforward or low medical decision-making. Level 2 will be a moderate level decision-making, and level 3 will be a high level medical decision-making, or you can bill based upon time if that's what's documented. So here's are the codes. 99221 through 99223 are the initial visits, whether the patient's inpatient or in the observation unit. The history and examination must be appropriate. The complexity, either low, moderate, or high, based on the same medical decision-making chart as our outpatient services. The amount of time is 40, 55, or 75 minutes for the initial visit. Subsequent visits, again, straightforward and low, moderate, or high for level 1, 2, or 3. And the time is 25, 35, or 50 minutes for time. The patient is admitted and discharged on the same day, straightforward and low, moderate, or high, levels 4, 5, and 6, or 45, 70, and 85 minutes. And if the patient is discharged less than or greater than 30 minutes, whether discharged from inpatient or observation unit, you choose the code based upon the amount of time. If billing based upon time, again, we mentioned this before, there's going to be an add-on code that will be available if the amount of time is greater than 90 minutes, greater than 65 minutes, or greater than 100 minutes for initial, subsequent, or admit discharge, respectively. Let's talk about some scenarios. Patient seen in the emergency room with a uretostone. The patient is brought in due to pain, undergoes a cysto stent, and is discharged that night. This is cysto stent using ICD-10 code N20.1 for uretostone, which is zero, and CPT code 52332 cysto stent, which is a 0-day global procedure. Will be billed in addition to the 52332, which the surgeon billed the 52332. The person who's doing the same day admit discharge will use 99235. We decided this to be a moderate level decision making, again with modifier 25 to show that this is separate and identifiable from the 52332. If the patient is brought in for a 52332 electively, then an E&M visit was done at a previous hospitalization, we would not bill an E&M service on the same day as an outpatient 52332, but it was reasonable that the patient seen in the emergency room, seen and evaluated, brought into the observation unit and discharged on the same day to bill 99235 in addition to the 52332. The same ICD-10 code will be used for the 92235 as with for the 52332. Same patient is brought in from the emergency room with the uretostone, brought in, they stayed overnight, underwent cysto stent the next day and discharged from the recovery room. Day 1 for the to be brought in 99218 through 99220 is the initial observation code. Really, the discharge from the recovery room is part of the 0-day global of the cysto stent, so wouldn't be considered that extended recovery and would not bill separately. If the patient is seen in the emergency room with uretostone, brought in, but actually developed fever and sepsis on the way to getting a cysto stent, but they're on the urology service, day 2, they're looking better, and day 3 discharge. Day 1 is the initial visit or initial hospitalization, 99221 through 99223, depending on time or medical decision-making. Use modifier 25 because CPT code 52332, which is the cysto stent procedure, is a 0-day global. Subsequent days, 99231 through 99233. And the discharge date from the urology service is 99238 to 99239, depending on whether it's less than or greater than 30 minutes amount of time on the floor and coordinating the care for the patient. Patient seen in the ER with uretostone, has sepsis, was brought to the medical service, same 3 days than in the hospital. And again, 99221 through 99223, the initial visit, if the patient's Medicare or an insurance that does not recognize consultation codes. 99251 through 99255, if the patient has a commercial insurance that recognizes consultation codes. A modifier 25 can be added to show that separate and identifiable from the cysto stent 0-day global procedure code. Day 2 and day 3 the urology service will bill subsequent visit codes because the urology service does not bill discharge codes because they're being discharged from the medical service and we're not doing the work of the discharge. Patient presents for radical cystectomy. The patient undergoes the radical cystectomy. All the subsequent hospital days, even if they're in the ICU, and the discharge has been paid already in the 90-day global of the radical cystectomy, reporting 99024 for our internal reporting system. It's not a billable number, but at least we know that the patients being seen will be reported. No billing will be reported, no discharge will be billed. Thank you. And again, please reach out with any questions.